Hi, welcome to the KaiNexus Continuous Improvement Podcast. I'm Mark Graban. Today we've got a conversation with two guests, two physicians. We're joined by Dr. Greg Jacobson, who is an emergency medicine physician, and you probably know him as the co-founder and CEO of KaiNexus. And we're also joined by Dr. Bahnsen Miller, an internist, internal medicine specialist. So Greg and Bahnsen, thank you both for being here.
Thanks for having us.
Internist is not the hardest word to say in the medical realm. I really stumble over words like podiatrist, but so Bahnsen, maybe if you want to introduce yourself, and I think it would be also interesting to hear a little bit about your story of how you were first exposed to continuous improvement concepts as a physician, or I'll try to say it again, as an internist. See, it wasn't that hard.
That's easy. Well, thanks for having me. I'm an assistant professor of medicine at the University of Virginia in the section of hospital medicine. So I practice mostly as a hospitalist, similar to an internist. I'm also involved in resident education, including various quality and projects with med students and residents. A little bit about my background. I'm from Louisiana. I went to Louisiana State University School of Medicine in New Orleans. I graduated in 2011. I stayed on at LSU to complete my internal medicine residency training. And then after that, I completed a one-year patient safety and quality improvement fellowship at Our Lady of the Lake Hospital in Baton Rouge. And that's really when I got involved in resident education and quality improvement projects, and had some exposure to KaiNexus at that institution at Our Lady of the Lake Hospital. And so, since then, I've been working with residents and students on various quality improvement projects, and kind of along the way, recognizing a lot of the challenges that the residents face, and faculty for that matter, with integrating quality improvement education, quality improvement projects with their residency training.
And maybe we can touch a little bit on patient safety and quality. I mean, how would you frame that for the general public listeners around some of the need and the importance around dedicated efforts around patient safety and quality?
Yeah. I think there are tons of opportunities in healthcare. I mean, dating back to error is human. We know there are a lot of opportunities in healthcare to improve the quality in the safety that we deliver. And around 2012, the ACGME, that's the Accreditation Council for Graduate Medical Education, they put out a set of initiatives, and quality improvement was one of those initiatives that they came out with, and that was for guidance for health system leadership, as well as the graduate medical education leadership. And they really laid out that quality improvement and patient safety would be a priority moving forward. And so that's kind of when the residents and medical students started getting a little more integrated with quality improvement and patient safety.
And Greg, maybe let me turn things back to you a little bit to think back to your time as a student, as a resident, as a professor, and some of your discovery of quality improvement practices.
So my journey precedes Bahnsen's a little bit. So I was a resident in emergency medicine until 2004, joined the faculty at Vanderbilt. And I'm sure I did a quality project as a resident because it was a requirement, but I can tell you this, it wasn't that big of a deal, and it wasn't meaningful. And, but I was always the person that was asking, what if we did it this way? And why do we do it that way? And so the chairman handed me Mizaki Amai's book, which I actually have it right up here. Mizaki Amai's book, I realize this is an audio, but Mizaki Amai's book, Kaizen. And, it really just transformed my life because it was this realization that there was this huge amount of improvement of knowledge or discipline that had been formed over decades, which interestingly started in the United States back in the 30s, transferred over in Japan in the 50s, and had really become a pretty robust body of knowledge and a framework that could really be applied to any situation, and the applicability to healthcare was not lost on me. And so there was this connection between the ACGME core competencies that preceding 2012, they were called core competencies. There were 6 of them. I think they came out in the late 90s, and they were really there was no prescription on how they should be done, and it was just these overarching principles. I wonder if they became more prescriptive in 2012 with what you're referring to. But one of them was called system-based practice, and if you read the system-based practice, you had the overwhelming sense that quality improvement was really what they were talking about. And so when Bahnsen reached out to me about a month ago, and he said, "Hey, have you ever thought of using KaiNexus in an ACGME framework?" It just reignited all these the historical context of how KaiNexus began almost 15 years prior. And one thing led to another. I was like, "Oh, we should kind of capture the real this kind of arc of a story of me almost 15 plus years ago having this realization, and then what's happened since, if that makes sense."
Mm-hmm. Well, thanks, Greg. So Bahnsen, let's bounce things back over to you. One thing you were talking about was the challenges that residents and students face. I was wondering if you could talk about, maybe there's 2 levels to that, or correct me if I'm wrong. There's challenges that come up in the day-to-day delivery of care, and then there are challenges that are faced in terms of improving care. Is that fair to say?
Exactly. I think residency training can be a very busy time, and residents are often pulled in many directions. So quality improvement, unfortunately, is looked at as kind of another task or another thing that has to be completed by residents, and it's not fully integrated into workflow. So time is often a big obstacle for the residents. Infrastructure is another obstacle. There are not a lot of faculty that have the QI knowledge to really coach or mentor residents. So that's also has been a challenge.
So Bahnsen, when you talk about infrastructure, could you elaborate on what you mean by a lack of an infrastructure, or what a helpful infrastructure is when it comes to improvement work?
Yeah, so I think it's the field of quality improvement is relatively new in the medical field, especially with graduate medical education. So you don't have a robust group of faculty at some institutions who are well-versed or formally trained in quality improvement, hence not being able to mentor or coach residents. So I think having the faculty mentorship is one opportunity there, and also alignment between the residency programs and the health system or the hospital in which they train. There's good intent between the residency program leadership and hospital leadership, but often aren't on the same page as far as working together to provide opportunities with quality improvement, provide infrastructure, certain resources, shared quality projects. So there's often a disconnect there, and I think that's another opportunity to improve resident engagement.
And then let's say if you had that coaching capability and alignment within the organization, I'm curious from your perspective what you've seen related to KaiNexus and the technology side of things. That if you had the other things in place, what other parts of infrastructure would be helpful, or have you seen be helpful?
Yeah, so the ACGME is part of the clinical learning environment review, in which quality improvement is one of those 6 pieces. They do recommend that quality improvement work should be interdisciplinary. So I can see where leadership could facilitate interdisciplinary projects, and they also recommend programs capture the activities that residents are doing. So I can see technology assisting with the interdisciplinary approach, as well as the tracking and recording of different projects. I think residents often work in silos, and so having something to help facilitate an interdisciplinary group or work would be helpful.
So Greg, let me kick it back over to you for your thoughts on this, or any follow-up questions you have for Bahnsen.
Yeah, I was gonna my one of my follow-up questions was gonna be, could you give some examples of some of the quality improvement efforts or projects that residents have been involved in that have been successful, and then perhaps some that have been, a struggle or haven't been successful? I'd love to hear kind of boots on the ground 2020.
That's a good question. I think a lot of projects are not successful, whether they start off really well and don't finish for various reasons, or just do not get buy-in on the front end. And that's a theme that we've seen published in the literature. So a lot of good intent by the residents, but unfortunately, a lot of the QI is not sustained or completed. So I think it's important to embrace their frontline perspective, understand what helps the residents, what they want to do. So instead of force feeding projects on residents, kind of letting the resident form their own project, kind of happen organically. Those are the ones that I've seen be most successful. I've recently worked on a QI project with transitions of care and handoff. So allowing some of the night nursing staff to write point of care or brief summary notes of the care overnight of the patient. So when the resident comes in the next day or during the day, they often don't have time or can't talk to the night nurse, but they can have a note to give them a brief summary of what happened overnight. So that's a win-win. It's more efficient care. It's informative. It helps the residents, but it also helps patient care. So I think picking the project is very important. Not rushing the project, having a good team will also help sustainability.
I'm thinking of two things when you tell me that story. One, I couldn't agree more with my experience in getting people to have buy-in to process improvement, quality improvement, continuous improvement, that there is this overwhelming urge to want to feed someone what they should be working on versus allowing people to engage in what's important to them. And so one of the things I remember that was really successful, 15 years ago when I was working on this with residents, was to identify what's frustrating to you. When you're kind of pulling your hair out, that's a great opportunity to think, wait a minute, there might be a process issue underlying this. Maybe we could work on something. And so I love the example of handoff. I mean, residents hand off to each other all the time. And so that's a pain point, obviously. And if you could help a resident or a group of residents work on, pain points that are meaningful to them, they'll want to engage. They'll have that intrinsic motivation to engage with it. But also, what's so amazing about continuous improvement is that safety issues and cost savings, which are kind of the two things you classically think of as like the big things, those often end up becoming side effects of other projects that really had to do more with satisfaction or just making it easier for someone to get their job done. And so I'm sure if we dove into this, handoff, there was probably an inefficiency component or a frustration component, but I'll bet it ended up saving, time, or it, created a more safe handoff, because obviously handoffs are the most dangerous part in healthcare. I don't know if you could riff on that a bit.
No, exactly. And that project came from the front line. So that came from the residents. It was their idea. It was something they had buy-in with, and it improved their efficiency and ultimately improved patient care through the transition piece. So I think that's really important. And that goes to show just embracing the perspective of the front line is extremely important when it comes to helping with projects. And I think we know, and you probably know this as an ER doc, a large part of the day is spent on indirect care. And as more and more work piles up, more and more patients, more and more, either the electronic medical record or residents being pulled in so many different directions, it's really important to nail down some of these workflow efficiency pieces and use quality improvement tools to do that. I think it's amazing. There is a large chunk of the day spent in indirect care for residents. So the more we can get the residents in front of the patient at the bedside on meaningful parts of patient care. I think that not only helps the patient, but also the education piece.
Yeah, I'm thinking of two things that I found that were successful when I was doing this, and they translate perfectly into continuous improvement in general, number one, but number two, even into KaiNexus as a company. But I like how you said that residents picked it. And so it sounds like it wasn't just one resident that was working on it. Maybe is that true? It was maybe one or two or three or a group. I find that when we have a strategic project here at KaiNexus, and back when I was doing improvements with residents in the emergency department, when you had more than one person working on something, it kind of creates a bit more energy, and it creates almost accountability almost becomes a little bit of a side effect. And I'm going to replace the word accountability with responsibility, because you've heard Mark talk a little bit about that. You realize that those words are synonymous, but one actually has probably better intent. And so everyone feels like they have a bigger responsibility to make things a little bit better. And then the second thing I wanted to say was, so one, put a couple residents on an idea or an opportunity for improvement. Don't just put one person working in silo. And then two, really pick something that's small. Overwhelmingly, what I saw was a resident will have an idea, want to get involved with something, and what they decide to bite off is really a complex problem that just the tentacles go really deep. So if you can get a resident on something really small in scope, the chance of success is way higher, because what you really don't really care so much if they're with the improvement that they're making, if that makes sense. What you really care is to develop a habit for these young physicians to realize that they can impact positive change in the workplace that they're going to be in the future. And hopefully so they can have this insight, when I'm a hospitalist or when I'm an ER doctor or wherever I go, this is some tools that I learned and that I can continue to apply. So pick something super small. They're going to be successful to develop that, to use a Duhigg's habit loop to develop that habit. So when they see a cue, they can do the routine and they can get the benefit. If they pick a project that's so big, they have to learn this huge body of medicine. They have to learn how to be a physician. It's just a lot to ask for. So I don't know if that's your experience, but small things, group things, those seem to be more successful when we're talking about getting residents involved in quality improvement.
Very, very important. I think one of my first mentors told me when we were kicking around quality improvement ideas, he said, cut it in half and then cut it in half again. So I love it. That's important. Residents are often not as experienced, and they do have big ideas and very creative. And I think that's another reason to engage the frontline residents. But again, they do need some guidance on scope of project. That reminds me of a project we did at OLOL on blood culture contamination. We noticed some in the emergency department and also in the ICUs. We had a fair amount of blood cultures that were deemed contaminants a couple of days later. And instead of rolling something out house-wide, we engaged phlebotomy, we engaged nursing staff and a handful of residents, and we just started in the medicine ICU. So we started in a small contained environment that was the ICU. We did a few PDSA cycles and got an idea of what was going on, why the cultures were contaminated. We looked at the process of how the blood cultures were drawn, and we really honed that in the medical ICU before we expanded it. Now I believe it's house-wide, or at least in the emergency department. So I think that was good. That was a good learning example on our end.
Well, and I think that learning points to some of the examples of the types of coaching you might have been referring to, Bahnsen, because I've seen in a lot of organizations there's a tendency to form a committee that's going to meet monthly in a conference room somewhere, where it sounds like you were helping guide people toward a much more active approach of getting out there, finding out what's really happening, and breaking the problem down. I think is great advice, making it small and go and test and do something. So I'm curious your thoughts on that idea or other elements of coaching that you would provide to people doing improvement work in healthcare.
Yeah, I think the prep work is extremely important. Assembling your team is also very important. If you can do that on the front end that will often save you a lot of headaches while you're going through the actual intervention. So that's something I learned as well. And understanding the learning environment of the residents. So another challenge is the rotations. So residents often rotate monthly. So designing a project, whether that's a small cohort of residents and students and attending just for that month, or you could consider projects on a specific unit that has residents rotate in and out. So just knowing the environment will also help with that buy-in and the success of the project.
Yeah, obviously a little biased being the CEO and co-founder of KaiNexus, but to me that's where back in 2005, when I started to think through this, why we initially went to email and then realized, we needed a piece of technology, because we needed a way to do asynchronous communication about this, because you have residents that are, in the emergency department, it's 24/7, 365. So you have some people that are on nights and days and swings and different ERs and whatnot. And so to me, I think that's where technology can really excel to bring all these people in. So if it doesn't get wrapped up on a 4, 6, or an 8-week rotation, that person still gets to follow along with the project and see it to its fruition. So it's certainly an opportunity to we always talk about, synchronous collaboration is where it's at. I actually think that synchronous collaboration is not where it's at. I think asynchronous collaboration is oftentimes as important, if not more important, to make sure that there's momentum to see things to its fruition. I'm wondering where you see whether it's. I'm curious. Is it AAC at GME or quality improvement in general, or at UVA, or just some forward-thinking thoughts along these lines of how residents can get more involved in what I think is the most important work in healthcare to date, continuous improvement?
Yeah, that's a good question. So like I said, in 2012 is when the ACGME put out guidance on quality improvement. And I think we still have a long ways to go with integrating and engaging residents. I think there's been some progress made in the education front, whether it's designing curriculum as a kind of an extra side, like a QI academy for residents, or some longitudinal education mixed in throughout the 3 to 5 years of a residency program. But I think the piece that's missing is more of the boots on the ground project work. And I think we have a ways to go there. Some of the challenges I know we already talked about, but I think faculty development is big. Just having more mentors and coaches helping the residents, and also more integration into the workflow that residents have. Again, we talked about residents being pulled in so many different directions. And if you can find projects or creating some kind of infrastructure around the residents to allow them to work on projects or continuous quality improvement during their workday or during their workflow, will, I think, help tremendously. But I think there's a long ways to go as far as residents and quality improvement projects.
One of the things that I can't help but think of is it probably makes more sense when you're thinking about a resident education in process improvement to teach 1 or 2 tools really, really well versus trying to give a huge survey. So I'm thinking, Mark, you've obviously, my paper about Kaizen, and it was in emergency medicine abstracts, if I'm not mistaken, back in 2008. Kaizen, a method for improving the emergency department, or something along those lines. But we broke down, initially the lecture was like 2 hours long, and then eventually it just became this 10-minute primer. I think there were like 12 bullet points of, these are the easiest things to think about. I think it was like non-value added steps, no idea is too small, but just teaching a couple of almost soundbite level things that are super easy to remember, that if you just apply these if everyone would just apply a couple of simple things for their entire career, healthcare would be way better off than, needing everyone to become black belts and having, extensive knowledge to be able to participate. If we just had just a couple, whether it's teaching 5 whys or whether it's teaching a good fishbone or whether it's teaching an A3, I mean, just pick 1 or 2 things and hammer those home versus trying to make everyone a CI expert.
Completely agree. I think we need to get back to basics. And some residents don't want to know much about QI, whereas some residents want to be experts and maybe pursue a fellowship in QI or a leadership role. So I think we need to get back to basics and, again, create something that's sustainable. So whenever you finish your residency program, you don't have a bad taste in your mouth about QI. You understand some of the basics. So when you go and practice on your own, wherever that may be, you have some tools on your belt that you can whether improve your patient's care or your clinic or whatnot. So I think getting back to basics is extremely important and focusing on just a few core pieces of education.
Sounds like really good advice. Of keeping things simple, going back to basics, taking baby steps. I think, I mean, I've received that advice and I've tried to pass that advice along through my work. So I appreciate you sharing that, Bahnsen. We really appreciate the discussion. Maybe we'll kind of go round robin and give each of you kind of opportunity to share one final thought for the audience here. Bahnsen, how can I ask you to? Well, I'll put you on the spot. Ask you to do that first.
No problem. And before we end, thanks for having me. I think we've made significant progress in quality improvement and resident education, but I think there needs to be a lot done to fully integrate the two, and mainly with project work. And so what can we do to engage residents on the front line, get their perspective and facilitate them really improving the care that they provide? I think it's extremely important. So I appreciate all the insight and thoughts and the work you all are doing, and hopefully we're moving in the right direction.
Yeah, that's great. So my thoughts to kind of wrap things up with regard to resident education, my challenge to people that are focusing on that is, does someone need to memorize one more piece of medical information that may change in 5 years or 10 years versus understanding the importance of having a methodology, having an approach, having a realization that our healthcare system is broken and that we all have a personal responsibility to engage in fixing what we can fix when we see things that are glaring, is something that I challenge really people that are training residents to think about right now. Do we really need the sixth thing on the differential for a disease, or should we just? I'm not saying that we need to spend 50% of our time training residents and becoming improvement experts, but having some thread throughout a 3 or 5 year residency that can build up these habits, I think will impact our patients down the road in more meaningful ways. And so that's my closing remarks, and I'll just leave it with a continuous improvement training and education for residents matters.
And I would chime in with a final thought. Involving everybody in improvement matters, and the lean methodology and the Kaizen methodology really encourages us to embrace and listen to and engage the frontline people doing the work, and that's physicians, and I see the heads nodding in our Zoom meeting here. I think that applies to everybody else working within healthcare. But I think when physicians and physician leaders really demonstrate that, there are positive ripple effects through the rest of the organization to help emphasize that improvement is for everybody. So thank you to both of you for your leadership on that front.
Thank you, Mark.
Thanks.
Thanks, Bahnsen. Thanks, Greg.